Thank you very much, Mike. Just before I open the floor up for questions, I see Dr. Unger's also in the audience, so I'd just like to extend an invitation to her if she wants to contribute to any of the answers to the questions.
Just raise your hand, Beth, so they'll know who you are. This is Dr. Elizabeth Unger. She's the acting branch chief. Dr. Unger is a pathologist, internationally known microbiologist, particularly skilled also in HPV and in a number of other areas, and we're thrilled to have her here today. Sitting with her is Dr. Kim Hummel, who is one of our policy experts and a laboratorian in the division where the CFS group is housed, and so they can help me answer any questions that CFSAC might have for us at this time.
Dr. Jason.
Well, Mike, I want to thank you for kind of making that data set available, or will be very soon. That really is very much in the spirit of other things that you have done for this committee concerning financial matters when we requested information, which you were very kind of forthcoming, and that really was very much appreciated by the committee members. I've got a couple of specific questions. The first really brings it back to the Science Day, where you saw, again, a number of presentations by several different people, some of whom are here. And I'm just kind of wondering if you can tell us any implications that you might have seen from stuff that was presented versus the things that might be going at the CDC, and also the standards. Do you feel that the CDC has the same types of standards that was presented there, and whether you feel the CDC is playing that leadership role that, of course, would be important? And the second question has to do with the case definition consensus meeting. I'm really happy that you're going to consider doing that with the CDC. I'm just kind of wondering, for the registry and for some of the recent publications, are you continuing to use the operationalization of the Fukuda criteria using the 2005 Reeves criteria, so-called? Is that still being used with these most recent publications? And if you have any kind of considerations to our group about the use of that, since it's the Reeves 2005 criteria continue to be a little bit controversial. And the third issue really has to do with the ICD-10. And my most recent looking at the criteria, which it sounds like the CDC possibly is doing some work with, I did not see either CFS or myalgic encephalomyelitis in most recent drafts anywhere within those frameworks. I'm wondering if you might comment on those three issues.
You're not asking a program person, you're asking an agency rep, okay? And so, Beth, you may need to help me here in just a minute. Get to maybe at the table up here at the front. Yeah, right up here. I think we'll have those available. The first question had to do with the standards. What? I'm not sure what you're asking about standards. Do we have standards? Of course we do.
I guess
going to have to clarify that.
So I'll try. It may be Beth, as you said, is probably the more appropriate person. You know, certainly, Beth, you saw kind of a number of investigators at the Science Day. I'm wondering if any of the type work that you saw being talked about has any relevance for the CDC program, and in terms of just the overall quality of the work, how do you think it fits with the types of quality of the work that's occurring at the CDC? And if you could just maybe talk about the comparison of those types of things, that will help our committee.
Well, CDC's program is science-based, so of course Science Day was absolutely, completely relevant. And the talks were all very good and will, be incorporated into our program. In particular, I guess it was easiest for me to immediately identify with the gene expression, genomics part of it. And it's very interesting, some of the findings that people are having in common as well as some differences. And so, yes, we will definitely keep all of these things in mind. The whole question of the heterogeneity of the illness, I think, was so clearly presented at the meeting. And that is something that our group and everybody, I think, dealing with this illness is starting to appreciate and needs to come up with better ways, which does segue into the case definition issue, if I could just go ahead and come to that. And one reason we didn't have a meeting yet is that we need to put into print and make available to the world what exactly we are doing with our data and our classification, because there has been a lot of misunderstanding. We are abiding by the 1994 case definition. Now, I think that it doesn't serve anybody to be a slave to any one definition, and what is more important than any definition is trying to come up with the optimal ways to give a full dimension to the spectrum of illness that are included in the people that you're studying. And so, as Dr. Miller mentioned, one of the very first pieces of information that we're pulling out of the Georgia follow-up surveillance, is an actual sort of 2-by-2 matrix, a comparison of how we would have classified them if we had done it the way that we did in Wichita versus the way we're doing it with the instruments. And so it's really only a difference in the way we apply the 1994 case definition. And I think that will go a long way to explaining the nature of, who fits one way versus the other way. And indeed, we have taken very seriously and read very carefully all of the very important criticisms and concerns that were raised by many in the committee and many other scientists about how we're using this case definition, and want to be sure that everybody is clear on what we're doing. And there could be, indeed, better ways to apply the instruments, but I think everybody would like to have as much precision and reproducibility as possible in the classification. But I think, again, the day of a simple CFS versus control situation is probably over, and we need to have CFS with a dimensionality in, be it fatigue, be it their cognition, be it sleep. There's many, many different domains, and I think that was another very interesting part that came out of the Science Day.
Did we get all Lenny's questions answered?
ICD-10, you said.
Oh, the ICD. Yeah, let me just clarify what we meant by that. After the first meeting that I was at of this committee, at the very, very end, there was a discussion about the ICD-9 and the ICD-10. And so what we did was we tried to, we met with the people that are charged with doing this coding to try to understand what it is. It's not in our purview to be doing the coding. So there is, in the ICD-9 clinical modification is the system that's being used now. The ICD-10 will be implemented at a later date, and there is a CFS in there, a CFS code that's under the symptoms chapter. There's also a separate post-infectious fatigue, which is under the neurologic chapter.
I just wondered, you mentioned the two different branches, the CFS working group and the retrovirology group. Is there a dialogue that's being established, or like regular conferences that are going to be planned between these two groups? And are there samples from the Wichita group or the Kansas group that are going to be tested when the testing becomes available for XMRV? Are there plans for that?
I'll answer the first part, and maybe Dr. Unger can answer the second part. Since the first publication in Science emerged, we have had almost, I guess, weekly or bi-weekly meetings, face-to-face meetings with the blood and tissue group, the retrovirology group, and the CFS group all together to discuss plans to move forward, what testing is being done, what testing needs to be done, who needs to be involved, et cetera. So yes, at CDC we've been actively engaged together frequently and continue to do so during this process. So Beth, if you could take that second part.
The question was specifically whether the Wichita samples would be tested, and they actually were part of the first study. And they are significantly depleted, and whether there'll be enough to be tested in a new round of testing is, we'll have to see. One of our goals is to figure out the best way to make additional samples available, and for that, we definitely need to wait until the optimal way of sample collection and processing is determined, because our processing, we were very careful to process immediately, within the first day of receipt, and perhaps that wasn't the best way for this particular virus, even though that's the standard for sample handling in general.
Lenny, then Steve.
I think Nancy also had her question up. Thank you for the candor of your responses, and that's very refreshing. I think that I have a couple just follow-up questions. One is that sometimes when one looks at biological markers and doesn't find it in 100% of individuals with this illness, it's easy to conclude that that biomarker isn't important. I think that happened with orthostatic intolerance with one of your papers. It's also happened with some immunological findings with some of your papers. So the question is, if one were to subtype and not sort of require those particular conditions, but say they're important, but they might not be in everyone, that's a different way of kind of reacting than to basically say this marker is irrelevant to the illness. So the question is, if one believes that, then I'm wondering if you can comment at all about the website in terms of the instructions at the CDC in terms of what types of testing individuals should have, where there's it seems like an absence of more biological markers. The second question I had has to do with, there's been a focus of some of the research recently on early childhood factors being implicated in the etiology of this illness. There's also been a number of factors that have talked about psychiatric comorbidity, and particularly recently personality factors. And I'm wondering if you might want to comment on the focus of those types of psychogenic research and whether you believe that individuals with this illness have a more high probability of having personality disorders, and whether early childhood factors are causative potentially for this illness. And finally, I wanted to kind of mention that some people within the scientific community as well as the patient community have indicated they've had difficulties in reaching you, in dialoguing with you since you've taken over as acting chief. And I'm wondering if you can comment on that and as a manifestation of the importance of being able to dialogue with the research community.
Okay. It's a lot of questions in there. Let me deal first with the website and the difference in the website versus what our research findings are. We don't immediately put our research findings onto the website. The website is what has been sort of tried and true, and for the general practicing clinician. And so while I believe biomarkers are tremendously important, we're not putting them out there yet to be used by clinicians because we don't know what they mean. It's still an area of research. And you're absolutely right, and that's about the fact that if you do a simple case control comparison, some important markers do not come out to be validated. And that is exactly why I believe dimensionality is needed and stratification. And so the fact that we do a case control comparison and don't find something, the data is still there. And yes, as we now start to understand that, maybe there is a need to stratify based on some of these other factors, we can always go back and do that. And ends up with small numbers, which, does limit some of what we can conclude. Now, and again, I don't feel I'm in a position to totally defend absolutely every paper. I don't have them all at my fingertips right now, but I can say in general, the reason that the early childhood stress has been published by our group and has been replicated as a risk factor. And what I think is significant there is not as much that it is a risk factor for CFS, but it has been a risk factor for many, many different illnesses. It puts CFS in common with a lot of other very good, biologically recognized illnesses. It is not unique or specific to CFS. It does not mean that everybody that has CFS has experienced early childhood trauma. And by the way, early childhood trauma includes a whole variety of things. And so it is one aspect that's an indicator of modulating biology that could affect the way a person responds to stresses of all kinds. And again, the word stress isn't as precise as we would like. But that could be a stress of an infection, a stress of jobs, all sorts of stress, that people encounter. So that is the context in which we are putting it. Is that enough? That's all I can remember.
Well, I guess just real briefly, do you feel that most people with this illness have some type of personality disorder, which might be suggested by some people looking at some of the CDC publications, and also the issue of dialogue with the larger research and patient community with your office and yourself?
And again, personality is not my area of expertise, so I will stand by the papers that CDC has published because we are very careful in what we do. I will say that I have been the acting branch chief, and I remain the acting branch chief, and therefore it's difficult for me to make long-range plans or long-range decisions. And so if I have been incommunicative, it's partly because I'm trying to move the program forward and feel it's not necessarily the time for me to be reaching out yet. But it's not that I want to avoid people.
Steve, then Nancy.
One of the bugs I'd like to put in CDC's ear is that whatever you define as the case definition and finally settle on, and I think it's a good thing that you're re-examining it, will have implications for people as they seek benefits through various insurance programs. Mm-hmm. We constantly see objections to or reasons for denying claims or limiting claims that chronic fatigue syndrome is a mental health condition. And there's so much scientific evidence, I think part of any criteria should address that it is a biological yes. condition yes. and not a mental health condition. And that would go a long way in helping some people
yes.
in yes. the world I live.
Right. Reminded me to say that the 1994 case definition was not a CDC definition, and CDC will not unilaterally be making a definition. It needs to be a consensus definition, and CDC's role any role would be to coordinate that and be part of a consensus definition.
Is there any time frame for when the consensus group will be put together, or thoughts about who might be part of that?
That's very, it's very early in the whole process. As I mentioned, one of the very first things I would like to do is to make it clearer the instruments that we've used and how we've used them, and how and to actually have the data then available for the community to look at how two different approaches to using the same definition impacts the people who do or do not meet the case definition. But it's clear that this is an issue that needs to be addressed.
Will you be looking at the Canadian criteria as part of the process?
Oh, yes, certainly.
Thank you.
Nancy.
Follow up on yours, though. I actually wanted to talk to Mike. Just to clarify, the Canadian case definition is the international clinical case definition. It's not the Canadian case definition. It was an international group that met in Canada, and so it's called the Canadian case definition. It's meant as a clinical case definition for you, Steve, and for the patients, so that you can use that in clinical settings. So that the research case definition, which historically always misclassifies some people, because its intent is to develop homogeneous groups and leave some people out, leaves people out, and the poor patients get stuck because they're being defined by a research case definition. So I know that when this group assembles, they'll be aware of all of that. But in terms of clinical and practical application, we should all be using the clinical case definition as much as we can in clinical settings, and we could also classify with the research case definition, whichever one you choose to be using in your research. So I'm just going to put that out there. I actually wanted to ask Mike a question, which has got to do with education. So I'm going to take the spotlight off poor Beth, who's been dealing so well with the spotlight, and let you deal with it for a minute, Mike. The education campaign that started some years back, a CDC initiative together with the CFSAC Association, put out an effort to reach the broader community and the primary care and provider community and make people more aware that there was such an illness and what the diagnostic criteria might be and so on. And there was a budget for that. And now I'm wondering what's going to happen next, because we still have this deal of 84% of the people in the country that have this illness having not been diagnosed yet. That to me seems like a health crisis and a very compelling piece of data. So do you know if
That's
there's
a very
any
good
plans?
question. I'm not sure that I can answer that. I do know that the contract, Kim, you can help me here. The contract with the Stevens Association, I think, is over, and I don't think. Well, I do know that there is another CME course being developed and planned, but I can't. I don't know how to answer that question at this point. It would be good to discuss that perhaps at the next CFIDS meeting. And it would not be a problem at all to bring an update on what the educational plans were for this group. Beth may want to comment further.
We definitely see this education as an important initiative to continue. And we're continuing it through making the website translated in Spanish, which we think is, it's clear that the Hispanic population has this illness and the information has not been made available. So that's one thing. The toolkit is now available in print form and is being distributed to local and county public health groups. And through the surveys of health styles and doc styles, we're monitoring the impact of what we have done to modify and guide what we're going to do in the future. So we will continue to have an educational component as part of the CFS program.
Thank you, Beth. Thank you, Mike.